For sleepwalking, obviously, a incredibly common thing in kids. 1 in 4 kids will do it very regularly. Sleepwalking is the commonest form comes from the deep sleep, non-REM sleep that I mentioned briefly. So people that have a sleepwalking tendency tend to wake up very abruptly, half wake up from deep non-REM sleep, and do stuff like talking, walking, or occasionally more dodgy things. Now, kids grow out of it usually, or they don't in probably about 2% of adults. Now, narcolepsy is a tricky thing, hasn't been studied much, but clearly people that have sleepwalking as kids, it seems to get worse when they get narcolepsy. So sleepwalking is part of narcolepsy. So that's a non-REM problem rather than a REM problem. But yeah, basically the whole textbook of sleep disorders can go wrong in narcolepsy. So, and that includes sleepwalking definitely, and sleep eating too. Quite a few people have an issue with eating involuntarily from sleep. It's education. I mean, the teachers need to be told that microsleeps, short naps, are part of narcolepsy now. I mean, in a sleeping child that has narcolepsy, often you can spot the eyes going in REM. You might get the teachers to look at that, and that proves they're in REM sleep. Often having wireless attachments, you can't prove it, but they should need to be told that this is narcolepsy. This is the essence of narcolepsy, is having uncontrollable sleep attacks. And, if they don't appreciate that, then it's their fault. My understanding is that the first therapy would be a talking therapy, counselling therapy. Then if that wasn't working, we can move on to pills and potions and drugs. I think drugs simply to suppress REM sleep, like the average antidepressant drugs, don't work particularly well. One drug I have here is talked about is a drug called clonidine, which actually, if anything, makes REM sleep more deep, it boosts it. So, which is interesting. So perhaps by increasing REM sleep in PTSD, you somehow deal with it. But I think the key therapy is talking therapy, counselling, rather than doing someone with mind-making drugs. But I'm not an expert in PTSD. Well, certainly having to deal with this kind of being half awake, half asleep, and having memories from dreams or from awake competing with each other. And that's really common in narcolepsy. In our patients, I hear this all the time, that they really struggle. Is that real or not real? I don't know how you deal with that. I think you just have to be aware of it and just let you know that I'll make your medication mistakes, and I'm sorry, it's my narcolepsy thinking and not me. So other than treating narcolepsy, I don't see there's any technique or tip I can give you really to help on that. In fact, the Xyrem has sorted out your breathing issues and making your PTSD interventions. The Xyrem helps to really normalise the sleep cycle. It's not rocket science, it puts you to a fantastic sleep at night, and your brain's allowed to be more in the day. So anything that's sleep related, a bit like PTSD, I would expect to be with Xyrem. So yeah, it's a bit of a wonderful drug, I guess. Yeah, absolutely, yeah. I mean, medical students I was taught this, and they still are. They're taught this so-called tetrad, the word for 4 things. They're taught about the sleepiness, the cataplexy, the hallucinations, and the sleep paralysis, and they forget everything else. So they focus on those 4 things, but it's at least 5 things, and the fifth, often the most important thing, is the overnight sleep. So I wouldn't say the majority, but a large proportion of GPs don't know that either. So they think it's really weird that you should give someone a pill to help their overnight sleep with narcolepsy. They can't get their heads around that. But it's total sense. Like Xyrem, being ultimately a hypnotic drug, puts you to sleep really well. And it works in the daytime. But GPs, if you offer people a routine pill for sleep at night in narcolepsy, they think you've been crazy. But totally, it's education. We need to teach medical students that bad sleep is part of narcolepsy.
The issue with narcolepsy, you're absolutely right. That I often pick things up on Facebook, I see things, and narcolepsy, is a disability, right? So whether you consider yourself disabled or not, that's actually irrelevant. Narcolepsy is a recognised disability in the UK. We have the Equality Act 2010, and disability is a protected characteristic under the Equality Act. Okay? It's that simple. So if anyone here ever gets any trouble from their employer, their school, their university, their partner, their whoever, just email us and I will quote them the Equality Act and they will go away.
That's probably just light sleep. You can be in light sleep with narcolepsy with your eyes still open, as you say, and the lights are on when no one's home. That's probably not rare, to be fair. But, well, it's probably a mishmash, to be honest. I mean, people that have narcolepsy in that state, you try to measure it. You know, you get bizarre stuff on the traces. It'll be somewhere in between REM, a bit of REM, a bit of light sleep, a bit of wake. That kind of a bit hodgepodge. The brain can't stay in one state. So, but yeah, I mean, I would stick with microsleep as the description. Probably not REM, but it could be a bit of REM. Well, certainly chronic sleep deprivation is now recognised to be the root of all evil. I hesitate to tell you this because otherwise you won't sleep worrying about it. But the ultimate sleep disorder anyway is shift work. People do shift work for years and years and years who are effectively sleep deprived for decades. You know, they have higher cancer, higher heart disease, higher mortality. It's really bad for your general health and your general stress levels too, I guess. People who have narcolepsy, whether or not they're sleep deprived is quite an interesting point actually, because if you look at the sleep the person gets over 24 hours, it's probably about right in all the wrong places and maybe the wrong quality at times as well. But there's a really good news, one bit of good news about having narcolepsy. In fact, I'm giving a talk next week to a bunch of doctors in York, as it happens, about Alzheimer's disease and sleep and how important it is for Alzheimer's and what have you. Now the good news is, if you have narcolepsy, well, the rats that have, rats and mice can be made to have narcolepsy if you fiddle with their genes and they don't secrete this chemical that you are lacking. So you can get quite a good model of narcolepsy in animals. Now, if you also give these animals Alzheimer's disease, which you can do, it's a bit bad luck having Alzheimer's and narcolepsy, but the mice that have both live far longer. So by giving them a bit more sleep, because they have narcolepsy, you actually seem to prolong their life. Now, I want to do this. I'd love to do the study. I would wager, we have a good bet, that the Alzheimer's disease is actually less common in narcolepsy, because effectively people sleep more, or they're awake less. It's not probably the increased sleep; it's the increased wakefulness or less wakefulness in narcolepsy that is good for your brain. The more the brain's awake, the more it's likely to get Alzheimer's. That's why sleep deprivation is probably a risk factor for getting Alzheimer's. But I'm rambling here. But so bottom line, sleep deprivation long term is bad for you. Whether someone with narcolepsy is actually sleep deprived is quite a hard thing to define, because it's random sleep.
Just a follow-up question about GP, because I was also to other people about the problem with that. I have a GP who says, I know nothing about narcolepsy,
Yeah.
just like that to you, and then they don't learn about it. So it just seems to me the day-to-day care and how it affects other conditions or how it might exacerbate other conditions.
Yeah.
Do you have any advice about how to advocate yourself better to your local GP?
Yeah, well, I mean, it's difficult. I mean, GPs are often the bane of my life when it comes to recommending things and either refusing or saying this drug isn't licensed, X, Y, Z. There's no easy way around it. I think you need a supportive sleep doctor to write to GPs and spit it out in words, 3 syllables that narcolepsy, through its effects, can affect everything else. Mood in particular, mental health issues. Diabetes, a chap mentioned he has diabetes and narcolepsy. Now, those two interact almost certainly. Yeah, it's education. It's a really slow process getting GPs. I mean, it's such a fascinating. I mean, from a medical point of view, it's such an interesting condition, narcolepsy. I really can't believe why it's not better taught and better acknowledged in medical students and young doctors. But it's so out there, so unrecognised, and so interesting to an average doctor. People that come and sit in my clinic, I mean, they always go away, I think, amazed at how fascinating and how important the condition it is. But it really isn't on the radar in medical schools. It's a very interesting and under-researched area, but there's definitely a lot of issues with metabolism in narcolepsy. And the commonest scenario is for a young woman to get it around puberty time and to put on massive weight gain at that time. Why? It's not quite certain. The part of the brain that goes wrong in narcolepsy is the part of the brain called the hypothalamus, which controls sleep, it controls appetite, and other kinds of things. So there may be an issue there. It's been shown beyond doubt that people with narcolepsy have odd appetites, so they'll have food cravings, often at night, for sweet things in particular. And the average narcoleptic patient will eat, so a person with narcolepsy, Matt has done it, the average person with narcolepsy will eat less than the average person, or will weigh more than the average person. So it's clearly a metabolic issue in narcolepsy, because you're probably eating at different times to when your body's clock is expected to eat. And also, something else, what was now? And if you have fragmented overnight sleep, some evidence too, that alters your appetite signals, so you'll be hungrier than average if you have a disturbed night's sleep. So there's quite a few reasons, in theory, why people with narcolepsy should have a weight issue. And also, obviously, the average person with narcolepsy probably won't be as active as, they will be having naps in the day, and might not be using up as many calories possibly. But that's not the key thing. The key thing is a problem with the brain and its controlled appetite and metabolism. And that certainly can be part of narcolepsy, definitely. I can't comment greatly on that, but sense of smell is said to be reduced in narcolepsy. There was a paper came out a few years ago, this chemical that was lacking in the brain called hypocretin or orexin. The problem is getting it into the brain of the patient, so you can't take it by tablet yet, you can't inject it, but if you sniff it in your nose, it does get a bit in the brain, certainly in animal models. So there's great hope for intranasal hypocretin. And when they looked at it first in humans with narcolepsy, it didn't really affect their sleep pattern at all, really. Very disappointing, but they actually had an improved sense of smell. So there's some evidence that the smell, I don't know why, it might just be but there's some evidence that people aren't so good at smell discrimination. Cure. Let's think about cure. Well, cure would be to stop the damage occurring to the brain cells, 45,000 of them, which sounds a lot, but it's a pinhead in 10 billion neurons, so it's a very small number of specific nerve cells that have this chemical we keep banging on about. How do you stop damage to those? Well, given that we don't know what causes the damage, it's a difficult one. So I think once the damage has started, it's very difficult to stop it from carrying on. It probably happens quite quickly, over a few days probably. Now, there's a big fuss, we may discuss swine flu at some point, but certainly in some inflammatory conditions, like a vaccination or a sore throat, or other infections can seemingly trigger the immune system and byproduct people get narcolepsy because they get damaged as part of the brain. So if you could stop anyone having any infections, you might help narcolepsy, but you can't predict that. So once the damage has started, I don't think fiddling with the immune system is going to be a cure. So I think curing narcolepsy is going to be a very, very tricky thing. But better treatments certainly are an option. And in animal models that are quite good animal models, if you can get this chemical that's lacking into the brain somehow, through a virus or squirting it in, it works really quite well, it seems. The issue is getting it into the brain. I mentioned the intranasal routes. There's work going on, and it's all undercover, but there will be a pill or injection one day to replace this chemical. In the same way that people have Parkinson's disease, take a drug that replaces their lost chemical called dopamine, and that works really, really well. So I think in 5 years, 10 years, who knows, there will be a treatment. I'm not sure what form of treatment, but to replace the lost chemical. Now that won't be a cure, that will just be paper over the cracks, but I think it will be the best treatment. So what until then, we have drugs to keep you awake, we have drugs to keep you asleep, we have drugs to suppress cataplexy or to influence REM sleep. So it's not ideal. The newest drug on the block for narcolepsy, some of you may have heard of, is called pitolisant. It's a French drug being used a lot in French teenagers. It's a histamine drug, so you're probably aware that antihistamines make you a bit drowsy, but drugs that increase histamine make you awake. Now, the trouble with drugs that increase histamine is they can have lots of side effects. But this drug is quite specific to this part of the brain that controls wake. So it's a very specific histamine drug. And I've started to use it in a few patients that aren't doing that well. And I've had feedback from 2 out of 4, and they think it's great. So early days, but this might be a new weapon. I suspect it's probably somewhere between modafinil and amphetamine in terms of its strength, but it works in a different way to these drugs, so I think it could be quite a useful drug as an add-on. I'm a bit nervous about recommending it too much because the drug company that make it are a bit small, a bit fly-by-night. So like Mazindol, something you may have heard of and tried and did well on, the drug company went bust and the drug was no longer available. So early days to be too confident about Tolzan, but it might just be quite a good breakthrough. Other breakthroughs, a bit thin on the ground, I'm afraid. There's nothing I'm aware of that's within a few years of being tried. It hasn't really been studied properly, but I certainly had patients report to me that they're in this dream, they wake up and they go back in the dream and they control it. They're almost using it as a sort of a game almost.
But in terms of brain waves?
No, it has to be studied. I mean, it has to be studied. It's too difficult to study that, I think.
Okay.
Yeah, it would be really nice to know, what's the difference between a brain that's doing that and a brain that's having a simple REM sleep. Yeah, it would be fascinating actually. Yeah, but it's a bit not far enough yet to do that. Some people do seem to get narcolepsy in the context of a brain insult, whether it's a head injury or maybe a brain infection. But normally it's just out of the blue sky. And this is my theory, and I'm not sure this is binding fact, but what I suspect happens is there is some sort of insult, some immune insult or whatever, that kills off maybe a third of the cells, say, maybe 10,000 out of 30,000. So the cells that are left have to work with, I mean, these are very hard-working brain cells, by the way. The hypocretin neurons and hypothalamus work at about 200 times a second. They're really active brain cells, which means they are vulnerable to cell stress. So my personal theory is that you get a bit of damage to a bit of the hypocretin system, and the ones that are left have to work doubly hard and basically wear out. They pack up after a few weeks, a few months, even a few years. And the reason I think that might be true is because there's a very interesting case study I saw recently presented at a meeting on narcolepsy from Ireland. And the Irish were very quick on the swine flu thing. And it was a woman called Kathy Crowe who had this case of twins. Now these twins, I think they were 9 or 10, they had the swine flu jab in 2009, and one of the twins, they were identical twins, but one of them got narcolepsy within a month of the swine flu jab, and it was, end of story, had narcolepsy, swine flu related, but the other twins was fine until about 2 years later, when she also developed classical narcolepsy. So they both had the same insult, but one had it quickly, one had it not so quickly. So to me, that implied there's some sort of insult that sets up a process that can either be quicker or a bit slower. So there's a degeneration of the nerve cells, is what I'm saying, as well as an insult.
It's interesting because my son developed narcolepsy following pandemics,
Right.
and within 2 or 3 weeks of vaccination, experienced 1 or 2 or 3 quite quick succession migraines that he'd never before had in his life and have never had since those occasions.
Interesting, yeah. Well, yeah. Migraine's interesting. I mean, a migraine is a nerve storm, is the word they used to use for it. And we don't think they cause damage, but some people have severe migraine and certainly have little changes of brain damage on their scans. Yeah, I'd have to think about whether that was relevant, but it might well be actually. Yeah, that's probably science fiction. I think we're looking at a chemical replacement rather than a physical replacement. Although, actually, I did my research years ago when it was fashionable to look at embryonic transplants for Parkinson's disease, and people have tried embryonic nerve cells in the animals, obviously not humans, and it's got some results. But I think it's going to be too difficult. The trouble is that these nerve cells, they go everywhere. They're one of the most wide-reaching nerve cells in the brain, actually. They're virtually all parts of the system. So to expect these cells to connect up would be, I think, too ambitious. I think it's going to be much easier to have a little, have the chemical there rather than the cells. But I may be wrong. But that I think it will be tens of years away. That sort of approach. The question, actually. actually. In theory, not a great deal, but other things kick in. So things like sleep apnea, things like general sleep-related, so age-related sleep deterioration. I mean, people don't appreciate, but age is the biggest sleep toxin out there. You can spot deterioration in your sleep quality from age 20, 25. Depressing, really. So it's all downhill from 20 regarding your sleep quality. So that will kick in, obviously, with narcolepsy. But the narcolepsy itself, it shouldn't really change because you've lost these nerve cells, end of story. People often thought their cataplexy gets better as they get older, but I think that's probably because they get used to it, they adjust to it, they avoid cataplexy situations rather than actually improving. But if people get worse with narcolepsy, as I said before, you always have another think about them, always think about other conditions that can easily kick in. You mentioned weight gain in narcolepsy, severe snoring is really quite a common thing. And other conditions like restless leg syndrome too, for example, very twitchy legs at night, that can be another factor in why they're having problems with their sleep and wake. Okay, I think this issue of the ultimate cause is the real. I mean, we know loads now about narcolepsy. I mean, it came out of total blue sky in 1999 when they analysed the genes of the Dobermans, the dogs in Stanford, that were bred to get narcolepsy, and it came out that these dogs lacked a chemical receptor in their brains for hyperprinting. And no one really believed it. It can't be simply due to a chemical deficiency. Yet the story panned out beautifully. So, it astounds me that you can lose, I said, a pinhead of brain tissue, lose a chemical, and get this disabling condition. There's no other condition like it. It's unique like that. But we still don't know really why it happens. When we talk about immune responses, if it was that simple, you have swine flu, cause a reaction, the next day you get narcolepsy. It doesn't work like that. There's delays, and some people get sleepiness for a few years, and then they get cataplexy. There's a progression to it. I think that progression, what makes these nerve cells degenerate or divert, I think that's a really important area for research. Because that might be a window. So if you can really spot the very first signs of it, maybe or some sleep disorder, to try and nip it in the bud, and then maybe replace the chemical a bit. So try and stop these nerve cells from totally going. Because once they're gone, I think after that it's damage and mutation. Well, we've said before that bad sleep in narcolepsy is definitely part of narcolepsy. And a lot of my patients, I recommend drugs occasionally. People don't take it up, and I have to do it myself, but a third of my patient group are probably on a pill at night to help them stay asleep. Now the trouble with sleeping pills is, well, there's lots of problems with them actually. The biggest one is that GPs won't prescribe them because I think get addicted and you've got acute insomnia go away. And I spend my whole time saying, we are treating a sleep disorder here, we're not treating insomnia. Get over it. But the other trouble is that they're not very good drugs because the majority of pills that make you sleepy, that are designed for sleep, for insomnia, like the Valium type drugs, like alcohol, they will make you sleepy, but they won't give you good sleep. Remember I banged on about those big waves, those slow waves, that's the good stuff, the deep non-REM sleep. These drugs inhibit that, so they give you light sleep. So anyone that's had a Valium might get 6 hours sleep, 8 hours sleep, but they won't feel zingy, because they're not getting that deep sleep. So the handful of drugs that will actually improve the deep sleep, well, this is only a handful. Xyrem will do it very well. A drug called pregabalin, which is used for pain and anxiety, is quite good at improving your deep sleep. Gabapentin, another drug for pain, not bad. Melatonin isn't bad. Agomelatine is an antidepressant, it's quite good, but hard to describe. Cannabis is good, quite good because they won't sleep. So people after cannabis sleep actually feel quite refreshed by it. So the studies are that if you want to use it, if it's easy to prescribe and legal, all the drugs out there, cannabis is probably quite a good drug for improving overnight sleep. Oh, good question. I would have said no, but I have seen patients who have surprised me. I remember a train driver who drove through a red light and caused a bit of a minor crash. People asleep, and it turned out he had narcolepsy. And he fitted all the I don't get cataplexy to be fair, but yet every other box he ticked. So he came to my clinic on treatment, on modafinil, and he did very well. And he wanted to get back to his train driving. So I said, well, we need to prove that you're doing well, so some testing, and he passed all the tests for vigilance, we tested for vigilance, and he was doing really well. So I thought, well, I think, yeah, we can argue you're now cured. And to my surprise and horror, he'd stopped taking all the medication. So he's on no medication, but cured. So I think he was a case of transient narcolepsy. Who knows what it was due to, some sort of brain inflammation maybe that got better. But he's exceptionally rare. So I think it would be pretty rare to have fluctuating narcolepsy.